I've not gone through residency training, so to write the application for a new residency program was quite the adventure, and to do that at the same time as we're writing for the first time a PRC application, that was a very memorable time, to say the least. Elaine asked for the official title. The official title of this SIP, this funding opportunity, and I'll say just a few more words about that. But the official title was Medical Resident Knowledge and Practice in Physical Activity, Nutrition, and Obesity Counseling for Primary Prevention of Cancer. Okay, this is pretty long. And as any good researcher knows, what is really important is coming up with a terrific acronym to refer to your study, because we don't use those long names. Our team and folks are up here in the front. They were instrumental in helping with the data collection. We came up with the acronym ONPAR for obesity, nutrition, physical activity, and in residencies. So I'm going to try this. I've never done this one before, but see if it's going to work. We're going to try the little lavalier mic that's going to record and then sync it up with the slides. That's the hope, which is why this thing is on here. Okay. So the plan here is that I would present the front ends, and then Heidi Gullett, who also is involved in this project, would present the second half of this. She's not here yet, so I might be on the spot. She is a practicing clinician and has a super busy practice, and I hope that she's just slightly delayed. If not, you'll forgive me for working with somebody else's slides and sort of winging it on the back end. We've talked about it a lot. We're in a good place with this. Other members of the team deserve recognition. Eileen C. Holzer, who has presented as part of the seminar series, was a major contributor to this. Our team, Bridget Jackson, Samantha Smith, Elizabeth Ann Pignoli, who are all here in the front row. Thank you for data collection. Huge amount of effort to collect this data and analyze it. And there are findings that are literally hot off the presses this morning that I just tucked in like 5 minutes ago into the presentation to share with you. Thanks to Samantha Sue Krejci and Peter Lawson, were also important contributors to this project and are here. And of course, it's been funded by the CDC. Let me move on this one. I'm going to give you a little bit of an overview here in terms of background and context. Some of this you will have heard before, but I've really oriented this towards folks who may not be familiar with residency training or training of physicians.
Where's Heidi?
Excellent. Heidi's here.
Sorry, I didn't know you. I thought it was
How you doing?
At your office. Sorry.
Welcome.
Running from another meeting.
Grab some lunch. How many folks here are clinicians? Okay, so that's helpful. You'll have some great insights for us and help us in interpreting some of these findings. Others will too, and I really did orient this from the kind of perspective that I have, which is as a patient, right? So I'm usually on the other end of this. But a lot of my research and work has been doctor-patient communication around health behavior change, health promotion, and how to optimize those conversations, but also how to tie into other resources within community. So what I'll give you is a little bit of a background around obesity prevalence, the primary care context, some what we know right now about current practice around talking about weight and weight management in primary care, and then in terms of the findings, what we're going to share, part 1 of the study, part 2 of the study, and some very preliminary findings from part 3 of the study, and then we'll open it up for, have some discussion points, and then open it up for discussion among the whole group. So in terms of backgrounds, there is a very high, and this is not new news, there's very high prevalence of overweight and obesity in the United States, as well as other countries. And I want to point that out because we are not we are not alone. This is not just a U.S. thing. This is a world thing. And the reason we care is that it is a major risk factor for many chronic conditions, including several cancers. And while we say that, I really do want to point this out. Most folks will be familiar with the things that are at the top of the list: coronary artery disease, heart disease, stroke, high blood pressure, type 2 diabetes. But one of the interests of the funders of this at the CDC is it is associated with some cancers, as well as liver and gallbladder disease, sleep apnea, and respiratory. I mean, there are a list of other chronic conditions that are serious that are also a concern with overweight and obesity. Like I said before, it is not just an issue for the U.S. It is a worldwide concern, and these data are old. Note that from 2008. I could not find an updated world map. This is from the World Health Organization. But the picture locally is not so good. We, particularly in Ohio, have a fairly high rate of obesity. Locally in Cuyahoga County, these data are being drawn from the Behavioral Risk Factor Surveillance Survey, as well as local data, much of which was generated from the Prevention Research Center, and then the rates in Cleveland. In fact, you may have seen the data brief that recently came out that was generated by the PRC, breaking down obesity rates by neighborhood clusters. Okay, so rates are quite high. When we are talking about the primary care context, and in some of my studies over the past 10 years of inviting adults who are coming to a primary care practice to see a clinician and engaging them in either survey research or observational research, we're finding that 70 to 90% of adults walking through the door are overweight with a chronic disease like diabetes, high blood pressure, high cholesterol, or are obese. Okay? And obesity is defined by a body mass index of 30 or higher. Okay? That's almost everybody. Okay? So when you ask, well, why is it relevant that you talk about this in primary care, or that primary care physicians might have a role to play in this bigger picture? This is why. Now, what do you do about it and how you do it? That's the bigger nut to crack. So we've taken the position that really there is an opportunity in primary care, and the question is, what do you do with that? The U.S. Preventive Services Task Force has made a recommendation that clinicians ought to be talking about weight and weight management and doing an assessment and recommending strategies. They recommend that the clinician refer to more intensive programming when the patient is interested. Okay. National Heart, Lung, and Blood in 2008 came out with some very specific guidelines to provide specific requirements and strategies that clinicians ought to be using, and they focus on two things, basically assessment and then recommendations for treatment. Some of the information is here. We conducted a study that audio recorded visits with adults. And these were adults coming to visit their primary care clinician. 544 of them were overweight or obese. And so we have an actual recording of when a discussion happened, whether or not that discussion around weight involved any of the recommended elements from the National Heart, Lung, and Blood required guidelines. So essentially what we found is that weight talk, and we define that very loosely, weight talk occurred in about half the visits. And most of that did involve an assessment. So basically something that came up that indicated what that person's weight was and that perhaps that was a problem, or perhaps was linked to or have it exacerbating a chronic condition, or suggesting that that might change, but did not make any didn't go any further. Okay, In terms of treatment, you can see on the list, and I should have brought a pointer, but you can see on the list the kinds of things that would count as treatment. So diet and exercise were the most common kinds of things to come up that would be treatment related, but really it was only happening, any one of these kinds of treatments was only happening in 38% of those visits. We examined whether or not patient and visit characteristics might explain whether or not these things were getting discussed or the degree to which they were getting discussed, and they did not. And I actually saw that as a very positive thing. So while clinicians aren't doing this, at least they're being even about. They're not focused on some particular group. Nobody's getting left out, right? Or they're not focusing their attention. They're equally poorly performing, if I may. Okay, lots of room for improvement. Okay, no shortage of people to talk with. Conversations are happening. They're not including elements we'd like. Okay, that's basically my next point there. So what are some of the barriers? No surprise here. There are several reports that physicians feel that they're inadequately trained, that they report low confidence or what we would call self-efficacy in doing this, or it can be an uncomfortable conversation. And they definitely report a lack of time. I would also add there's a lack of reimbursement, although that's a little bit of a moving target. Okay, so we already talked a little bit about this special interest project and its unique nature. I would say this was probably the most, this was a fairly prescriptive project. The CDC was very clear about what they wanted to know and what they wanted to answer, and it was our job to come up with a strategy of how we would go about that. And we were fortunate enough to be selected as the group that would get to do this project. So this was indeed competitive, and there was some working together, some collaboration with the CDC and their team in terms of what would get included in our survey, and they really were involved in the overall approach. They were explicit that they were interested in 3 primary care disciplines: family medicine, internal medicine, and OBGYN. They had a special interest in cancer, and so we included a section on cancer, and knowing that obesity was a risk factor for some cancers. But they were predominantly interested in senior residents, and we'll explain what that means in just a minute, being prepared to address obesity counseling, and they wanted to know about their knowledge, their perceived preparedness, their self-efficacy, and attitudes towards doing this kind of counseling. So here are our study aims. We've broken it into 3 chunks, and I basically described these as the 3 phases. First was to conduct a survey to understand residents' knowledge, attitudes, and self-efficacy. The second was to identify the scope and modalities of training, so to really understand what was going on in their training program towards preparing them to do this kind of counseling. And the third aim was to take a look at, do these training characteristics affect what we see in terms of attitudes, knowledge, and self-efficacy? Okay, so those are what I'm referring to as the 3 phases. Okay, so how did we do this? There was a cross-sectional, this is a cross-sectional study, and we conducted a survey with the residents, and we also did interviews and document review. So this was a mixed method study. The interview and document review, originally we were going to interview the residency director or associate director, and based on what we learned from the very early programs that we went into, expanded that to include chief residents, and then any other faculty that we could get a hold of that seemed to be knowledgeable, that could contribute to our better understanding the nuts and bolts of the program. The document review, there's something called a PIF, a Program Information Form. It sounds very nebulous. It is a very fat document that basically tries to describe all the components and elements. Am I doing okay? all the components and elements of, remember, I'm not a physician, of that program and that training program. That document is can be helpful. It's sort of what they say they're going to do. The degree to which it's really there and happening every year is not 100% true. We asked for lists of seminars. We asked for lists of any kind of didactic lectures, any kind of documents they would share with us. We had a specific list, but we would take what they would share and then filter through all of that. Our analyses were predominantly descriptive statistics. This team did structured coding of interviewed data and extracting things from those documents to get key variables. And then we have some bivariate associations. In terms of the sampling, one of the reasons I think that we were selected for the grant, Ohio has 54 residency programs. When we wrote the grant, 54 within the state. That is incredibly high. So 54 that were either family medicine, internal medicine, OBGYN, or some combination. There are some states that don't have any. There are some states that have one. This is a very clinician-rich state. So we had lots to choose from, and given the budget and the timeline, what we chose to do was sample. But what you see in this table here is the total that we had to select from. We had proposed in the grant a target sample of a minimum of 24, and then we ended up going with 25. We were aiming to select to maximize variation, and we could talk more about that, but we wanted to vary by discipline so they're all represented. Program size, which is relative. A big program in internal medicine is 50 trainees per class. A big program for OBGYN is 6. Okay? So they really vary. It depends, and that'll be our answer to a lot of things. But we also wanted to vary by a geographic distribution. Okay. Okay. The resident sample, senior residents, what do we mean by that? So residency training, and Heidi's going to talk just a little bit more about that to help give an orientation. But for family medicine and internal medicine, that is typically a 3-year program. So we were talking 3rd years for internal medicine and family medicine. And for OBGYN, that is generally a 4-year training program. So we took, because they also tended to be small, we took 3rd and 4th year residents. In terms of the data collection, we were charged by the CDC to achieve, and guarantee we would achieve, a 75% response rate from these residents. So there's snickering. You're crazy, why did you agree to that? I asked myself the same question. So we decided that the best strategy was to capture them while they were in a conference that was a required conference, introduce the opportunity, and then provide the program back something that might be perceived of value. And that is our ace in the hole, Eileen Seeholzer, high energy presenter of all things obesity. So she really does a terrific job on providing information around obesity management and strategies and rationale for it. It was not a happy place for me to have to fill those shoes on a handful of times when I had to go do that presentation, but I think I did okay. I can now talk about that, and I'll show you some slides if you like. So we had other strategies. We provide this presentation, but basically we asked people in attendance to complete the survey. If they weren't there, we tried to track them down. Our measures included knowledge, self-efficacy, attitudes, and some demographics. The knowledge questions, when we first did our pilot testing, we wanted to make sure we had variability. Okay, we could represent the variability. Most knowledge questions, people were getting them right. Okay, so what we did was really ratchet this up, and we made it very difficult and framed the questions much like they would be for a board exam. We actually used those frameworks, and we achieved what we wanted to achieve. We got scores that were nicely spread out. All the items were really working. If anybody got in our pilot testing, if items were all correct or all wrong, they were excluded, and we went with the items that really differentiated. This is just an example. I think I'm going to skip over these things. We went back and forth several times with the CDC around the number of items. There was at one point in time when they wanted us, I don't know, it was like 105 items. And I'm like, this is just not. So there was a lot of negotiation. We winnowed it down to this. Survey length was still an issue. I think I've already talked about these things. I just want to be mindful of time. Okay. I'm going to share this one and then introduce Heidi. And she's going to take it from here in terms of the results. And I think that we've done it in a way that's flexible enough that if you have questions or we want to go in one way or the other, we can definitely do that. So I do want to fess up about the 75%
62%
response rate.
Darn good.
So we worked really, we all of us here, thank you, worked really, really hard to get folks to answer this. And there were a lot of incentives involved. We had differentiation in terms of participation across programs. So family medicine, I apologize for the abbreviations, but family medicine was close. Internal medicine, those were the biggest programs, and they were the hardest ones to get. So when there's 55 in that class, and you're trying to get all 55, they don't all show up at the same place at the same time. There was one time Eileen did 3 presentations for one site because the group didn't meet all at once. So in our effort to capture that, it's a significant amount of effort. These were our additional efforts to boost response. I wish we had done this in a way that we knew from the beginning that we could really test out this as a methods approach. But certainly the in-person surveys helped. If they weren't there, if they weren't there, we sent them an email and offered an opportunity to do it as an online survey with a gift card incentive for Starbucks, something like that, Starbucks gift card. Then we ratcheted it up and had a raffle for still those non-responders. Out of every, 100? Every 50? We bumped up the ante and said it was a $100 gift card. That didn't buy as much. We got 10 surveys. Okay? And then there were some mailed surveys where we asked the chief resident to, we gave them envelopes, and an envelope for all the residents. It was either a thank you letter for completing it or a survey. So it was blinded, so they just handed them all out. So anyway, our yield was not terrific. The in-person survey and then offering it online seemed to have the best yield. Okay, so Heidi Gullett, before we come up. So Heidi is an assistant professor in family medicine, community health. She has an MD, is double board certified, family medicine, preventive medicine, and has an MPH, Oregon. Okay, sorry. Doing this on the fly. But Heidi has taken a big role. She was a major help on this project for sure, and now has a major role in teaching Block 1 in the medical school, and I think has an opportunity to move some of these ideas or some of these structures into perhaps, or at least can help us frame how some of this stuff might fit into medical school training as opposed to residency training, which I think is going to be a key take-home point. So with that, come on up, Heidi.
Thank you so much, Sue. Again, I apologize for my tardiness. And
No
thank
problem.
you so much for allowing me to tag team with you today. Participating in this study has been a huge learning experience for me, and really grateful to the team. I learned a lot from all of you. And So we decided to give you a little bit of the results and then take a little hiatus to understand a little bit about medical training. I thought everybody understood how people become doctors, and then I went to medical school, and my mom was like, so when are you a doctor? And, my family was calling me a doctor after I'd been there like 3 days, and I'm like, oh, you really can't do that. I don't know anything. So I'm just going to give you a little background about training. We did this with the research team, too. We spent some time sort of thinking about how does training actually happen, and how do we best frame our surveys, but also our results. All right, so these are the resident characteristics. Again, we collected data from the junior residents, the interns, first and second years, but we didn't include that in these. So we've gone round and round about how should we include those, should we analyze them, and what do they mean. But for this, you're looking only at those senior residents. We collected some demographic data around who went to U.S. medical schools because we thought this may have implications for undergraduate medical education, as Sue alluded to earlier. And you think, oh my goodness, 27% of them are chief residents, but in OBGYN, they're all chief residents the fourth year. So if you're looking at it and think there are a lot of chief residents out there, they all have some role in certain specialties. So you can see the breakdown in our specialties as well. We'll talk a little bit more about specifics in the next few slides. So the summary scores around each of these domains are on a 100-point scale. And I thought that was when Sue presented, I thought, that's a really helpful way for me to understand. I'm learning how to do these sort of studies. And so looking at the raw data, for a while, I thought, how do we make this understandable? But I think this is really understandable for the average person. Our target for this first dissemination is probably program directors, graduate medical education directors, and those people are busy, and we know they're going to read the abstract and flip to the what do I do with this information. So our goal is to make it understandable. So you can see that in the counseling knowledge, we had 54, but in cancer risk knowledge, it was actually significantly higher. And so Eileen and I were wrong. We both thought that would be lower. And when the CDC first said, we have this cancer focus, we thought, okay, I don't know that the residents are going to get this, but they proved us wrong there. And then looking at attitude and self-efficacy, and you can see here the spread. Look at self-efficacy, right? 0 to 100. These are pretty amazing findings. And if you have anything, to add and we can jump in. But we really want to sort of get some feedback from the group about how to frame some of these.
Could you define that self-efficacy?
So 12 items, right?
Yeah, there are about 12 items. Self-efficacy is your level of confidence in being able to do the activity. So in this case, your level of confidence in being able to provide advice around how to eat right, or So I think what the important thing, one, what Heidi pointed to is the spread. The other thing to take note of and pay attention to, because it's coming up, is how big the standard deviation is. Okay, so because we see some, that's an indication of spread, but it's also an indication of effect size when we're looking at differences. I usually put it back into, well, how big, how much of the standard deviation of it is. And we usually care about things when we're talking about attitude, self-efficacy, knowledge, anything that's around a 0.35, 0.5, a standard deviation, we care about that. If it's up to one standard deviation, that's a big difference.
17 points.
That's a big difference. So
we're going to revisit that.
That's
standard deviation.
So remember the magnitude of those standard deviations.
Did you have something else?
So why don't I wait to ask that question?
Okay.
Yeah.
All right.
When you start talking about self-efficacy, then
Sounds great. So in looking at these associations between counseling knowledge and demographics and training characteristics, we took the first set of these data to say, let's start thinking about the residents from the beginning. And then when we start analyzing further the program. So I think we've started to do that a bit, but we really have a lot about actual residents. So we looked at who are these residents, where do they come from, where did they train, and you can see we use family medicine as a reference, and you'll see that in each of the subsequent tables that family medicine is the reference. So this one, counseling knowledge. Do they know what they're supposed to do? We didn't see as much variation as we will when we get to self-efficacy here. So cancer risk knowledge, again, really they did fairly well on this. This is the kind of stuff they study for on board. These guys are, anybody who goes through a residency is a good test taker because they've been taking tests for quite a long time. So some of this particular cancer risk knowledge are things that they're doing in these board-style questions. Did you have?
Let me just orient for people, because there may be some folks who don't know what we're looking at here. So the left, so these are the characteristics we're looking at that would be associated with counseling knowledge. The beta coefficient is this indicator of degree of association and direction. And then this is our p-value, the standard errors, the amount of spread around our. So what we're looking at, for example, is individuals who participated in an elective rotation that was related to, an elective that was related to anything close to obesity, nutrition, physical activity counseling, showed that they were 5 points higher on their counseling knowledge score than those who did not participate. Okay, so if we remember, the standard deviation around that was about 12 or 16, something like that. So it was about a third to a half a standard deviation, which ends up being marginally statistically significant. But overall, there weren't a lot of characteristics that were strongly associated with knowledge.
You didn't think all those ones? I thought race, citizenship, medical, those are all significant. And 6 points is pretty high, isn't it? It's a half a deviation. It's a half a standard deviation. Surprised.
Yeah. Well, so that's what we're looking at is the mag. I would pay much more attention to the magnitude effect than the p-value.
And the elective rotation, we're going to come back to in discussion, but that's across all of the specialties. But some specialties had more opportunities than others. And even within the specialties, some programs had little to no opportunity and others had significant. And I know you guys can speak to that, as you know these programs better than any of us do. So, okay, so now that you're oriented to the table, you can sort of see these changes here in cancer risk knowledge. Not entirely, anything hugely significant. But when we start looking at attitudes, we start seeing things be a little bit more associated with particularly opportunity for elective rotation. So we start to see that not only are they potentially getting more knowledge, but they're potentially also changing attitudes. And we'll get to the self-efficacy in a minute. So, physicians may be forced with very short period of time in a particular clinical encounter, but if they have a paradigm that is really orienting them to the importance of this, that may make a big difference. They have to learn a lot of stuff, so how do we make this be among the most important things that they learn?
So, I'm sorry, did I miss that the attitudes, the higher the number, the more positive the attitudes towards doing this?
Yeah. All of the scores, and sorry, I should have said that too. All the scores are going in a positive direction. So higher scores, higher knowledge, higher self-efficacy, more positive attitudes.
So even though, like, for example, the race differentials, even though there was less knowledge against, the comparison, they actually have higher attitudes and more positive attitudes about doing it.
Correct.
Okay, correct. I just wanted to, it might help to.
More positive attitudes. Those who were non-U.S. citizens, the U.S. citizens had significantly lower attitudes.
But higher knowledge, which is very interesting. So even though the knowledge was there, the perception of that it's important was not there.
Mm-hmm. And then in thinking about their self-efficacy to actually do it, we can definitely see that there are some really significant findings here. So if you look at family medicine as the reference range, and you see, okay, internal medicine, again, this is a negative half of standard deviation here. So looking at OBGYN, that's an entire standard deviation. And then if you look at the flip of elective rotation in ONPA, that's a whole standard deviation the other way.
Wow.
So
there's your zeros.
Yeah. So what was your thought around that?
So how is all this correlated with the BMI of the practitioner?
That is a great question. We actually talked about this. Eileen really brought this up early on in one of our conversations. So not measured in this particular study, but has been in others. And so I don't know if anybody on the team wants to comment on that. But Eileen has a wealth of knowledge around, and by the way, she's traveling or she would be here, but she has a wealth of knowledge around when a provider has been challenged by obesity and has tried to make changes and then come back to the patient encounter with their own sort of thoughts about how it did work or didn't work or what worked for them, that really changes how they do the encounter. But that's not something that we studied in this particular study.
And are you or anybody else looking at results on the other end? Did those who had good attitudes, self-efficacy, and so on, who do the counseling have effects on the patients?
That would be great if we could do that. It is out of the scope of this particular study, but something that I think if we're going to really truly understand both undergraduate medical education and graduate medical education, if we're going to adequately address this epidemic in a meaningful way, we've got to figure out, does it make a difference for the patients? Because we can test all of the factors on the resident side, but if the patients don't get any sort of benefit from it, it's probably not effective teaching. So, do you want to come in?
Yeah, well, I'll bring that up in the discussion.
Okay, and then we're looking at professional norms here, and so I don't know if anybody wants to comment on the particular items within this, but again, this is about, it's not necessarily attitude or self-efficacy, but it's about a professional norm and thinking about the value of obesity, nutrition, and physical activity, and you can see an elective, again, makes a difference here.
Yeah, and I'm sorry, we added this at the last minute, and I'm realizing I didn't follow my thread all the way through. Professional norms point to whether your supervisor, whether your preceptors, whether your peers, whether your professional societies think that obesity counseling is important, right? So it's your perception of how others that are supposed to be important to you professionally view that activity.
So that might, how does this correlate with the BMI of the residency directors? So, it's a cultural thing.
It is very much a cultural thing, yeah. Absolutely.
That's what we're talking about. Look at that map went by fast. But look, which culture is this arising in?
And organizational cultures and programs all have a different culture among them. So even different specialties, we all make jokes about this specialty has this personality and this specialty has another. And Eileen and I joke all the time about that. She's like, you're just that family doc thinking about counseling, But the thing is, there is a reality to that. So there's a reality that within specialties, but within programs as well. And some of these questions were things like, my attending faculty think this is an important thing for me to be doing. Those are the kind of questions that get at this. Those are the items that get at this professional norms. So, excellent point.
Yeah, but I was going to ask you though, because I only think I've read one thing on this, but I actually think in your question though is that, isn't it also though that it may not be the extremes of obesity of the physicians or the directors, but I think it is what you're saying is folks that have actually challenged it, they probably are more likely to see this as a norm, not negatively. You didn't follow the next statement?
Because I haven't done a review of the literature, so I don't want to misrepresent.
Yeah.
But in talking with Eileen about this very issue, she said that when people have struggled themselves to make change, they sometimes don't think that change is possible, particularly when there are other issues around that patient. So contextual issues, environmental issues, and that sometimes becomes a bigger barrier, and that they know how hard it is themselves, and so that may be not facilitating the actual weight loss for the patient. So, I myself, in full disclosure, don't know that evidence, but I know we've had discussions around this, and it's an important issue and one I think is worth pursuing potentially. Okay, so very briefly, I know some of you have gone through medical training, many of you teach medical students, but in that question my mom asked me, I'm just going to sort of throw this out there, not to think that any of you don't already know all of this, but undergraduate usually is required to have a bachelor's degree before matriculating into medical school. Not always, but usually. There are some 6-year BSMD programs like we have at Neomed. U.S. medical schools, and I clarified that because many of the respondents in our surveys were not from U.S. medical schools, and so that's a totally different structure. They are required to take the U.S. medical licensing exam, the USMLE exam, in order to be licensed to practice in the United States. But those are different structures. But in the United States, it's typically 4 years, 2 preclinical, 2 clinical. And they take different licensing exams as they go through. But from the very beginning, they're doing those board-style questions. So from the very beginning, we tried to give them things that they've been seeing for the last 6 years, the type of questions. Then you'll notice that in the past 10 years, I was the last class to get through before this was instituted, was to do clinical skills. So we actually have to go to a site and demonstrate with standardized patients that you can talk to a patient. So I think that's relevant for this study, and I think it's not entirely rigorous around counseling, but at least you can talk to a patient. So those are things you have to do before you are going to be in a residency. You receive an MD or a DO, and there were MDs and DOs included in this study upon graduation from medical school. And at that point, you are a doctor, but only eligible to have a training license, so you need to be in a residency program. You can't just go out and hang a shingle. The match process, which many of you see, it's always on the front page of the Plain Dealer, day after the match, is when a computer sort of generates where people are going to end up based on the preferences of the program and preferences of the residents. So very quickly, the lingo is the internship year is that very first year. In some of our study data, you'll see PGY1, that's postgraduate year 1. That's just a way to say it's your first year out of medical school. It doesn't always correlate with actually when they graduated. So you can have a PGY1 who's been out for a little bit, but that's where they are in their actual training and residency. And after completing that first year, you're eligible to take the last USMLE and actually get an unlimited license in practice. So you don't have to finish your residency to do that in most states. For this particular study, we looked at these primary care residencies. So 3 years, as Sue mentioned previously, for family medicine, internal medicine, 4 years for OBGYN. When you complete a residency successfully, that's accredited by the ACGME, which I'll talk about in just a minute. That's the accrediting body for graduate medical education. It confers you board eligibility, but you still have to take exams in the case of OBGYN to actually be board certified. Fellowship is additional time, and I didn't specifically go into the longer surgical fellowships because it's not as relevant here, but for these particular specialties, they're usually a 1 to 3 year fellowship, which could be accredited or unaccredited, meaning it could lead you to an additional certification and it may not. The reason I'm including this is that we looked at whether there were fellowship opportunities in the programs that participated in this study, because we found that there, in some cases, were champion faculty who set those professional norms and helped residents potentially achieve improved attitudes and self-efficacy because they were doing it themselves. Example, sports medicine, something like that. So we've already talked about this pretty extensively. I just put it in more for, I know that the slides are posted in a sort of reference for folks. This includes the boards for each of the specialties. And there is a much stronger emphasis in the intern year in all of these specialties toward hospital medicine. In the second and third year in particular, family medicine diverges a bit from internal medicine. And clearly the scope of family medicine is prenatal care, pediatrics, all the way through geriatrics, whereas internal medicine is adults. OBGYN, again, crosses the spectrum, but there's significant procedural orientation. And I bring that up because I think we start to see when there are competing curricular demands, it would sometimes be hard to get curricular real estate for stuff like this when you're trying to learn how to do a hysterectomy.
So, and isn't pediatrics usually included in primary care?
It is, and when our original proposal, we put that, and we actually talked about preventive medicine too, but the CDC was very specific about wanting adult primary care specialties, so it was not included. But yes, we would consider general pediatrics to be primary care, absolutely. So this is also, just to sort of orient you when we're talking about professional norms, in the interest of time I'll skip over it, but attending is that person who's the supervising, fully board certified and licensed physician. And oftentimes that's the person who a resident would sort of talk about as the champion, as the person sort of setting the curriculum around this. And some particular programs had entire curricula around this, but it was sort of the champion that was pushing that. There's always an inherent tension, too, between learning and service. Providing service and enough learning is really a challenge, and it's something program directors in all specialties deal with. But I think when we're talking about how to make change around curriculum, that's a big issue. We had trouble and you guys can speak to this more than I can, in getting in. People are like, our schedule is set for the next 2 years. It's a 2-year curriculum. There's no room for you. You know, not that they didn't want to include us, but it's tight. Okay, so these are just some fellowships that may be relevant. You can look at them later if you wish. The reason I included this is accreditation is different for undergraduate and graduate medical education. We're trying to target an audience here. We're really looking at graduate medical education with these study results, but we think there are implications for undergraduate medical education, and we can talk about that if folks desire. The ACGME is moving from only these core competencies, which things that we think these 6 competencies residents should be able to be good at upon graduation, was a little nebulous. Like, how do we actually assess that they're really good at these 6 domains? So they've moved to a milestone program, which basically gives concrete examples of where you are in that progressive responsibility and that maturation in your professional identity. And so we have more concrete examples, and they're very specialty specific. So we pulled them as we're starting to think about our discussion, and as you would expect, OBGYN is very procedurally oriented. They can do a hysterectomy independently. They can do prenatal care independently, whereas family medicine, there were a number of domains that talk particularly around counseling and about relationship building with the patient. So I just bring this up because it's important for our discussion points. All right, so program characteristics are here. Again, as Sue said, we really try to be diverse. There are some community-based programs, some academic university-based programs. We really try to make sure we hit them all, suburban, urban. The payer mix in the clinic is something that we looked at as well, because many residency practices tend to have a payer mix that looks different than private practice. And some of them have a mixed attending resident practice. So we tried to look at that just to have some more information. And then the variability in the number of programs, number of spots in the program. So I mean, you know, we've had residents 4 a year and some 55. So it's really a challenge to. So in our last few minutes, Sue, I just want to see how you want to manage because we have a lot of slides, so we can.
You know, why don't we do the program characters? So this is the main stuff for research question 2, and then maybe we should move to the discussion.
Okay, great. So the team painstakingly went through all of this information, qualitative and quantitative information about how much was really being offered. So you can see that number of didactics, hours of didactics per year. Yeah, it looks like a lot, but when you think about it, it's really tight as far as what all real estate needs to be covered. They still need to know how to manage bread and butter conditions. And then hours related to these particular topics. So you can see the percentage is very low.
That's the average across programs.
So 25 programs. And across specialty. So the other thing we found is that there were a lot of formal and informal ways in which this is taught. So sometimes the informal ways were really hard to assess. I mean, they did an incredible job of extracting tons of information and then categorizing it, but it's really hard sometimes to figure out, are they really informally getting this? And then particular specifics around health behavior change counseling techniques that are specifically taught in the program. And then, again, we tried to sort out, are there electives or tracks offered? And do they offer fellowships which would normalize some of this, the importance of some of this, which may change their responses? So we categorized the fellowships of whether they would or would not be relevant as related. And then, are they offered in those particular programs? And then you'll see down here that a lot of times folks were kind of creating their own electives. So that's another sort of, if it's there, they might do it. If it's not, they may do something else. We have a lot more information about the program characteristics. Again, I sort of already alluded to some of this around inpatient time, ambulatory time. And then we really try to get at an interprofessional component. So are there other professionals who they not just say, you need to address this, so see a dietitian or see somebody that can help you with exercise, but do they actually engage in professional encounter and understand what each other does and have respect for that and work as a team like this?
Can I ask a question? Are you going to maybe talk about this? Because maybe getting at the question of not knowing, you said about the comparison, but you can look to see if programs say they do this formally and they really do give opportunities, are the residents from, you're able to track, right? Does it make a difference? Do they have more confidence? Do they have more efficacy? Is that the next question?
Okay, let's go to the next
Okay,
one.
sorry, that's the.
This is hot. This is hot off the
Off the
presses.
presses.
So let me. I don't want to put Heidi in a bind on this one because I literally just inserted it at about 10 to 12.
Do you want that mic?
No, it's okay. I'll talk about it. So we selected a couple of elements. So on the left, you can see the subheadings: counseling, knowledge, attitude, self-advocacy. We picked a couple of outcomes. We picked a couple of characteristics about the programs that we thought would have an impact on knowledge, attitudes, and self-efficacy, like whether or not they offer specific, the number of hours spent in on-par related, or obesity, nutrition, physical activity related didactics. So, is that right, Samantha?
If they had any.
Any. So having any related, so no versus yes, our mean knowledge score, it really not that different, but 50 versus a 55 in terms of the knowledge score.
Yeah.
Okay, so it's not a strong effect. Across all of these things, the story's about the same.
The attitudes are huge, though.
There's
so the perception, right? Knowledge.
Yeah, but it goes in the wrong direction.
Come on.
Mm-hmm. There is something about, and I think it's going to be tough to tease out. So these attitudes, I think it has to do with the more you learn about it,
The harder you know it is.
you're like, wow, that's
Which gets back to
challenging.
that same issue if you've tried it yourself.
That's difficult. I would have expected that more of the self-advocacy, and to some degree we see that a little bit. But, I mean, it's certainly like, yeah, can you do counseling and then you take a class on doing the counseling techniques and you're like, man, that's tough. How, that's really tough until you really, really dig in and do skills practice kinds of things that you actually learn how to integrate that in. So basically what we're seeing so far, and I think the main point from looking at these other characteristics, if I can go back up, there is not a lot going on. And this was one of the comments after doing the first couple of programs saying,
Ain't much there.
what are we missing? And we're like, well, you're probably not missing anything because it just isn't happening. We went in with an expectation that this was happening a bit more in terms of the curriculum. And the answer is it really isn't. So on this, we had organized this in terms of here are really formal opportunities that all residents would have an opportunity to have exposure to. And as Heidi would, and there's not much there going on in terms of focus.
3 hours.
And this is based on the documentation they have, their schedules of lectures, the interviews with multiple people, the program director, the chief residents, any kind of champion we can get a hold of. It's not there. It's not there in the real estate. And it's there a little bit more in informal ways. But the deal with informal ways is, when you have a preceptor, not all residents get the same kind of level of exposure to that preceptor, right? So it's not that everybody gets that experience who's coming through that training program. So it may be happening a little bit more in informal, but it's certainly not happening in a formal way. And the characteristics that we thought might be strongly associated don't seem to be strongly associated. But I'm not that worried about this. I think the fact that it's not happening, it's happening at such a low rate that if we're comparing when it's happening versus not happening, I wouldn't expect dramatic effects because it's so not happening.
Wasn't there a characteristic, though, of the individual that said they something at the very bottom, like 17% did?
That resident actually said that they participated
elective rotation.
In an elective. They personally reported, yes, I did that elective. People who did the elective, one standard deviation higher in their self-efficacy of doing it. So we have that direct, so it does seem to matter for residents who participate. The other one that we're looking at, is it available? Is it part of the context? Is it part of the environment that they have that opportunity? What we don't really know, except from the resident self-report, is whether or not they partook in that.
Yeah.
It's interesting stuff. I think there's lots of
opportunities for, oh, there it is, okay. Okay, I think we'll just move on to the discussion points. You're it.
Sounds good. All right. So clearly there's a lot of variability in the preparedness. So it's important to have knowledge around counseling skills and knowledge about what you need to do, knowledge about the actual subject matter of obesity and its context for the particular patient, but then also to actually have the skills to do it. And we see variability across all of that. And we really think that there's a lot of room for improvement, particularly around what we were just talking about with this movement around electives. So I think we've really reviewed all of this already as far as the hours. Yeah, we kind of, so I don't know, do you want to say more about?
Can I ask one more clarifying question? The efficacy questions, is it efficacy that I can talk to a patient, or is it efficacy that I think I can help a patient change behavior?
It's predominantly the first.
Just, can I just even talk
the
about
attitude, I think we captured the, if I can have an effect, is more around their attitudes. Doing this is going to matter.
Okay.
My patients want me to do this.
Okay.
So it really is that I've got the skills to be able to have this conversation and be effective. I mean, we do ask a little bit about effectiveness.
Okay.
The strengths and limitations here, I think I think this is unique. Other data that's out there, and I honestly haven't looked for the last couple of months, but tend to focus on a program or two or one university-based program. So I think it is a great strength. And I see Amanda out here, and I have to give props out to the CTSC PBRN for helping, because when we were trying to put this grant in and say, can we actually get these residency program directors to agree to participate and get letters of support from them under a very tight deadline, we did get some help in making calls and following up with residency program directors, who are not easy people to get a hold of, nor do they answer their email. But this is a unique study in terms of its inclusiveness, and that it is, a large sample of programs. It's not a national sample, but it's a large sample of programs of which we have good representation from each program. Pretty good representation from each program. So I think that's terrific. But I do want to open up for conversation. I mean, this is really the gist of what we have to share here. We are three different pieces. What is the current level of knowledge, attitude, self-efficacy for residents? What's going on within these programs in terms of what they're offering? And does there seem to be an association between what's being offered and having an impact on scores? So there's a couple of explanations. It is possible that these residents are coming in with skills, attitudes, and knowledge, and that the incremental push of what's happening within residency programs is actually quite small. Maybe most of it is coming from where they train as an undergrad being medical school. Possibility. It's possible that they're coming with skills not even from medical school. Right? Maybe it's coming from somewhere else, that they're just much more prone to being able to talk to somebody and feeling comfortable with counseling versus something they're much more comfortable at being somebody who does procedures and has those technical skills. So I think there's possibilities, but it also points to, if we go back to the very early slides, right? So the U.S. Preventive Services Task Force is recommending that counseling happen. If that's the case, and we're going to hold folks to some level of performance on this, how do we support that? How do you create space in the real estate of curriculum to make it happen? And what is it that needs to shift in order to accomplish that? Or do we just
It strikes me, going back to the first question, which is what's the underlying research that leads to that recommendation? because it does, the most troubling one is your last slide, because it would suggest that even more training might not yield much. But you almost want to go back to the very beginning, and that is the research say that if physicians actually counsel, people would lose weight? Or is it just that if a person in need hears it from multiple sources, of which one of those sources is this important relationship, maybe physicians would not have as much feeling such responsibility, that it's not about whether or not I'm going to sit with you and put a diet together with you, or I'm going to do this. It's just me telling you I care about this and it's important. Would that change would that lift off the shoulders? Like, it strikes me that the front end should drive first. Like, what is it that we really think? Are we really thinking physicians are going to spend 15, 20 minutes? No. So if that's what I think, if residents are thinking that's what counseling means.
So we can flip to some.
So this is, I threw these in here because this is what we share with the residents and point to. So there's really 4 things to recommend. It's a nice package of stuff, but it basically takes some of the burden off. And I think that if you do look at the recommendations, while the clinical guidelines are different, the recommendations from the U.S. Preventive Services Task Force is that there is an assessment done, it gets documented, and the recommendation is that there's referral to more intensive, right? So more intensive assistance in terms of nutrition, diet, and weight management. But having the skill to be able to say enough to promote getting somebody, or to be making that referral and actually having somebody go, is really what we're trying to get folks towards. And the one thing that I think is really, I'm not sure really going or not, but setting a weight goal. There's an article that came out, it was probably in the mid-2000s, that said, what do patients want from their doctor about this? And they want a realistic goal and some ways to achieve it. Okay? So what is a realistic goal? What do you guys think is a realistic goal for weight loss? They have a clinically important impact. You guys can't answer that.
Yeah, it's 5%.
5%. How many people think it's 5%? How many people think it's more like 20, 25%? People aren't guessing. Okay. All right. So how many people think it's more than 5%? Okay. It actually is 5%. So 5% of losing 5% of your weight, if you're overweight, obese, losing 5% of your body weight has an impact on multiple outcomes, okay, with clinical relevance. So things like your blood pressure, your cholesterol level. I think you actually have to lose a little bit more for triglycerides. I think it's closer to 10%. But blood pressure, triglycerides, cholesterol, there was another one in there, your glucose. So you can have a clinically measurable impact by just 5%. What? 5%? We're not, that shifts the game. And that comes back to a comment that Ron had earlier of, what really is the goal? And I think the goal is setting a goal of 5%, having a clinically relevant change in outcomes, and if you meet that goal, terrific. You can choose to set another goal. But we're not moving towards trying to get to an ideal body weight, because that actually may not be achievable for most people. Are there other comments or questions? Ideas? Amy?
Two different directions. One is whether you looked at, or maybe it's a subject for future research, the use of clinical decision support tools that might be built into EHRs that can help providers implement guidelines on how, when to refer a patient and what ancillary testing to do. There's an NCQA standard around weight management, and that might be something really interesting to look at, whether people who are at an NCQA certified institution do better than people who aren't.
Yeah.
So,
There certainly are tools out there. The EHR, I think, can help. Elaine had mentioned David Lydecker, and so David Lydecker, for a while, had a role at the VA, and he said, I remember a specific conversation with him. He said, Sue, guess how many EHR prompts and alerts I have? And, I don't know, 10. 84. 84. And how you deal with that in an 11-minute visit, I don't know. So I'm not sure if when an alert becomes an alert anymore when there's so many of them.
Yeah.
So I'm not sure if that's the right thing to do. But I think there is something about the context, the tie with chronic disease, measurable clinical change with a change in weight, the relationship, and knowing that you're going to see these patients over time in a primary care context, that there's an opportunity to help motivate and connect. And how we do that and trying to figure out what that role really is and how best to do it. But then I guess this project was much more around how do you sort of set that and incorporate that into curriculum for residents or maybe even earlier medical students. There's some ideas here, yeah.
Do any of the studies that you've looked at or any of the work you're doing look, since time is limited, working in the community, working with groups of people, rather than one-on-one individually, 11-minute sessions or whatever?
Yeah, there's a lot of literature on that, and I wish Eileen was here to comment on that because she has developed a curriculum that is really peer-led. And I guess the question is, if you can attract people that way, great. If clinicians sure would like to know about that, to be able to say, hey, Jane, if you're ready to, talk about this, or you think that this would be a good one for you, here it is, and here's info for it. But certainly that is absolutely, this is by no means saying that this is the only approach. We're just saying, here's a sliver and an opportunity. How do we make the best use of that opportunity and then connect to other things? Sure.
And I think that the other thing that we've talked a lot about is at what level of prevention are we really aiming at? So is this truly primary prevention? Because if we're talking about this with regard to cancer incidence, it's primary prevention. And that's typically been the realm of local public health. And we know that those level programs have not necessarily been that effective if not engaging in smaller groups, So I think that there's interest in this on a number of levels. Is it from primary all the way to tertiary prevention? And I think that's a really great opportunity to think about when we're shifting the lens a little bit further upstream. Maybe that also could be an effective avenue. And the other piece of it is there are a number of folks working on shared medical appointments and obesity and weight management. And so while that's still provider-led to some extent, it does also bring in a nice small group piece. And so the clinician would be able to potentially kind of bring the best of both worlds together. And I know, Mary Ann Tomego's been doing a lot with that as well, at the clinic. So anyway, my thoughts.
There was one other question here.
No, I have just a little suggestion. It's very important that study that we are going to train the physician about the obesity knowledge, and their index might increase, but due to the limitation in their time, we can treat them to manage this in a way of their staff. They can organize it, and it might be a better way. Since patients have to wait anyway in the hospital for a long period of time, it might be a process of the visit. If we include in that might be very helpful to manage it, because the physician might not have the time to counsel, but the staff might have.
Mm-hmm. Right.
If we can share the responsibility among them, that might help.
And certainly some groups with patients out of medical homes and having, multidisciplinary teams engaged, where there are many visits where the clinician is not engaged at all, would be very, very appropriate, very good. Let's take one more question. I want to be just mindful of else's time.
So I'm not, I don't know that I have a question, but I don't know where to kind of start. So my original training in nutrition was from my mother. She graduated from Mather College as a food and nutrition major. And so I, in 1941. And so I learned about diet, nutrition, and vitamins and minerals over the dinner table. So I think that what goes on in the family and the family habits are, study after study, whether kids do their homework, whether they, it's the family. And so that'd be the one thing that, I would always, in my practice, of course I was very attentive to this, would focus on, well, what are the needs of the patient, what do they want to accomplish? Mm-hmm. And very often they don't want, it's a social thing. Mm-hmm. I'm not sure where to start, except that I would just tell them things that I had learned. Breakfast is the most important meal of the day. Do you have breakfast? What do you have for breakfast? If you have if your meal is colorful, it's a balanced meal. If you don't bring it into the house, the kids won't eat it. Things that were just simple messages. Call a friend and go for a walk. Not 10,000 steps. It's not doable. It intimidates people. I think that we're trained to be very intellectual and data, and I think I think we need real simple steps. You like the commercials you watch on TV? Climb the stairs once during a commercial time. You'll be amazed in a couple months the difference that'll make. So it's these simple little things that are part of the context of their lives that I had a lot of time as a psychiatrist. That was never much of an issue.
Yeah.
I also have other backgrounds that landed me. A case in the 50s started, you didn't get a pregnant woman or a woman pregnant, that's our joke. They would they had a program where the students worked with an obstetrician, then a pediatrician, and followed a woman who was pregnant, and they had their baby, and all kinds of family issues were addressed, and it had a perspective on the first-year students. We interviewed, and this started in the 50s, mock interviews. And so, actually, as you were talking, I was wondering if you could go to case graduates and find out what case graduates thought. The first year in medical school, and this was, of course, right up my alley, it's an integrated curriculum, and they made great efforts to integrate. And so there was an article published in New England Journal, I don't remember what year, by Cahill, and it was a review article, Starvation in Man. So they used that article and kept referencing that article through first year, which, I know and remember a lot of metabolism involved with nutrition. And it was right up my alley. I don't know how much others absorbed about that.
Yeah.
So,
to go on here, so one of the things so there are a bunch of messages that we try to leave the residents with. And it's a helpful perspective, it's particularly around the goals, because I think that that's a major aha, and it is a relief. It's a weight off the shoulders to think about just a 5% goal, and that 5% goal matters. But we also give them other points, and I think some of these ones at the end, it's just to be mindful, and I think many clinicians are, that patients are coming to them from complex situations, and that just do it is not always, the way to go, but being mindful about the other environments, that some of the meds that they may be prescribing are actually, adding to the difficulties, but it's that bigger picture, family context, and being mindful of that, but also this idea of that, you're suggesting it, and it's relentless, right? So it's not something that, it's something that you're going to come back to, it's something that you're going to encourage.
If I make one last comment, I think is the difficulty of this is you start at the front end often with your talks with all of us is that we talk about population level obesity. And then we zoom in to individual level change. And it's very true that individual level obesity may be about calories in and calories out kind of thing, but that's not the answer to population level statistics in obesity. And that's where I think the misnomer comes, because it's not that public health efforts have failed or that even these efforts will fix it. It's got to be, it's not how we got here.
Yeah.
In other words, so folks, yes, people's individual BMI may be a relationship to their individual choices, but those choices are far more complex than
Right.
the decisions they're making on a daily basis.
It's thinking
right?
about
And you know
the-
that's the
Right,
It's
and
thinking
not
about
really
the
energy
pipe.
in, energy out. That's a really,
Well, that's
that's
a
a real
whole other-
problem
yeah,
too.
too,
What's
yeah.
been, the messages that have been drilled into the public over the last umpteen years, which are misconceptions, are a problem. Huge
Okay,
problem.
I'm going to call
I
it.
know, yeah, yeah.
Everybody, thank you so much for your time and attention today. Thanks for all the comments.
Very good.